Welcome, everyone. We're so excited to be having this event, Bridging Research and Practice for Aging and Disability Services today. My name is Felice Triergoff, and I support communications and dissemination for the center that is organizing this webcast, the Center on Knowledge Translation for Disability and Rehabilitation Research, or KTDRR. All of KTDRR's activities are supported by the National Institute on Disability, Independent Living, and Rehabilitation Research. I am supported by a great staff here at KTDRR, our director, Kathleen Murphy, Tracy Ballman, Brian Litke, Shoshana Rabinovsky, and Amanda Seagroves, just to name a few. I'm an Asian American woman with shoulder-length black and white hair with bangs, and I'm wearing an orange dress with a black pattern and pink headphones. I am thrilled to introduce Dr. Shonda Schrader, who has nearly 15 years of experience in rural health, research, evaluation, and knowledge translation. So she knows this content very well. She serves on the editorial board of the Journal of Rural Health and is a member of the National Rural Health Association. Dr. Schrader is a professor at the University of North Dakota School of Medicine and Health Services. Dr. Schrader, are you ready to begin? Great. I invite you to introduce yourself and self-describe.
Excellent, thank you. So hello everyone, I am Shonda Schrader. My self-description is that I am a Caucasian woman with shoulder-length, wavy brown hair, not wearing any glasses. I'm wearing a thin blue and white striped sweater, and I have buttons over my left shoulder. A brief positionality statement for myself, given that I am a professor in a Department of Indigenous Health, is that I am a non-Indigenous and aspiring ally that works as a professor within the Department of Indigenous Health, really trying to focus my tools and resources for students and offer them knowledge and teaching around research methods, public health evaluation, and health equity research broadly. Prior to my role in the Department of Indigenous Health, I was the Director of Research and Evaluation at the Center for Rural Health, also at the School of Medicine and Health Sciences, which is where I am bringing a lot of that expertise today to share with you all. I do want to just preface that I am here today as Shonda Schrader, and I am doing this on behalf of a private LLC of Health Equity Research and Assessment, so these positions and views do not reflect those of my university. So as we continue today, I do like to provide just a little bit of an agenda so you know where we're headed and what direction we're going to go in. I am going to talk to you a little bit about knowledge translation in rural areas, about engaging audiences in research, and then provide for you some examples from work that I have been engaged in my academic role. My primary goal today is really to ensure that university-based research that is focused on aging and disability services lands in the hands of those who can actually make change and develop community-level interventions, especially in rural and under-resourced areas. For those of you who are able to see images that are on the slide today, I just want to share that the pictures are selected with intention. They do not supplant anything I am saying, so if you are not able to see the photos, you will hear everything you need to from me. However, if you are able to see the images, they have been uniquely selected to show the diversity of what it means to live and grow up in rural areas. And so I hope that they at least offer just a little bit of a break in text for those who are seeing the images and to know that they were selected with intentionality. So you all understand the broad concept of knowledge translation. You've been a part of these groups for a while, and I've been told you're well versed in this area. But what I do want to do is really stress that when your audience includes those who are harder to reach and who are too often not taken into account for knowledge translation, we need to be creative in how we reach these communities and recognize that there are still best practices for working in these spaces. So people living in rural areas and those who are in other ways underserved, like those who utilize aging and disability services, are frequently omitted from knowledge translation strategies. Or They're simply lumped into the group as a whole and assumed that if knowledge translation works for this group, it works for all groups. But this merits additional tailoring of products and outreach methods if we want them to actually reach our rural and underserved communities. New relationships have to be forged so that informational exchange can actually be grounded in trust. And I think we recognize that now more than ever, even following the pandemic, where we really started to have this struggle of what are my trusted sources of information and where can I turn? So I am going to push for a little bit of engagement. I'm not going to force you to come on camera, though I make my online students do that, my doctoral candidates. I am going to ask you to engage in the text box as you are able and just share with me honestly, where do you consume new research or health information? Do you turn to TikTok, radio, television? I'll give you a minute to respond in the chat if you can. How do you honestly consume health information and research? One has shared that they check peer-reviewed journals. Another has shared conferences and social media, peer-reviewed journals again, and social media. So we're getting a bit of a balance between that. Databases like PubMed. If I quickly want to know, I'll Google it first. Don't apologize for that. We got a sorry with the, I'm sorry I Googled first. That's not something to apologize for. What we're trying to figure out is how are people trying to figure out information? So we put our information there. Others have shared podcasts, newsletters, journals again, and databases. Pretty much always journals. This person said never anything from social media. And then this one said also alerts from journals. These are all great answers. So I'm going to keep that. You can keep them coming in because I'll draw on this a little bit as I talk. And I was hoping somebody would say that recently I've been using AI to help me find articles. Great. So one of the things I want to stress right now is with many academics in this audience, or at least those who have access to academic journals, if I am trying to reach rural providers or individuals who provide rural disability services or aging services, almost none of them actually have free access to academic publications. Journal articles typically have a paywall. So then we're stuck thinking about how can I translate this information and this knowledge to the individuals I want making decisions, to those I know need this information. And then we start thinking about open access journals and how can we make our work accessible and how do we get individuals to then understand the academic jargon of peer-reviewed work. So hopefully today I'm going to give examples of how we can do this in rural spaces and not just present you with problems. So effective dissemination, it's simply about getting the findings of your research to the people who can make use of them. You want to maximize the benefit of the research, and typically we want to do that without delay. And I stress the without delay because those of you who have maybe written a journal publication, you know that you will write an article and it can be 6 to 12 months before it's actually released. Between making revisions, getting acceptance letters, going through the publishing phase, and then having to wait until its release date. That's not research without delay. So how can we do this in rural spaces? Things that will help you do this effectively is to ensure that you plan early. Before you ever do research, it is really important to develop a communication and a dissemination plan. I don't want to give you more work. It doesn't have to be formal, but at least with your research team, create some sort of guide of how you plan to communicate during the research with community and how you plan to disseminate throughout the process or at the end. And I'm going to give tips on how to do this. Stakeholder engagement is also really important. And if stakeholder isn't the term that you are comfortable utilizing, think about community partners. Essentially, you want to work out who is your primary audience and how can you engage them early. Keep in touch with them throughout the project, not just at the end when you say, how should I share the results now? And not just at the beginning when you ask, what should we study? They should be involved from the planning all the way through the dissemination of the findings. Another strong principle of a good dissemination plan is to think about the format. Think about your targeted outputs that are an appropriate format for the users you want to reach. So consider tailoring them to match your audiences. Are you looking to reach a national audience? Are you looking to inform one particular community, a subset of a community? And I'll provide a little bit of a concrete example of that in a moment here. It's also important that you utilize networks. Given the network that you're all in, you may have a lot of colleagues. I saw some share in the chat and said, colleagues are where I turn for information, or conferences are where I go. And that's excellent. But sometimes we become so ingrained within our own networks, we forget about those outside of ourselves. A great example is that those who work in rural health have so many small, tight-knit communities that are the Rural Health Caucus of the Public Health Association, or the Rural Health Network within the state offices of rural health, or the Rural Health Unit of the Mental Health and Services of America Agency. And so they stay within their rural pockets and forget that if their results were particularly about women's health, for example, maybe they should work out in networks dedicated to health and services for women, and then just introduce rural. So that's just an example of pushing yourself outside of your comfort zone of who is your normal network, and think about other networks that align with the research you're doing. Also, a strong principle is the context. So understanding the service context of your research and thinking about who champions or influential leaders are in the topic area that you're studying, and planning for the timeline. When will you share and disseminate this work? And most importantly, when doing a strong dissemination plan, know your resources. And I don't only mean how much money do you have to pay for open access, or how many dollars do you have for travel to present this work, but also know your own resources. Can you design a really good infographic? Do you have that talent? Do you have somebody within your network who does? Because the last thing you want to do is discredit the amazing work that you've done and the results that you have found by making, and apologies for not having a better term, but an ugly infographic. We've all seen really bad infographics or poorly designed presentations or posters. And if that's the case, even if your research is fantastic, it's not going to be consumed. So thinking about what are your own strengths and abilities for dissemination as well. Now I want to shift gear just a little bit and talk about how you can do this work effectively in rural spaces, because a lot of those tips that I've shared so far are something that we should put into practice when doing a dissemination plan, regardless of our research population. But when you're moving into doing research in aging and disability services and rehabilitation, and you want to do this work specifically in and for rural, you have to think about, what do you mean by rural? And I want to do my own sort of soapbox and really stress that rural is not monolithic. So if you have worked with one rural community, you have worked with one rural community. And it is not all agriculture, which is oftentimes what we hear in news media, and when we are even reading articles that are written by hospital staff or academicians who don't actually work or practice in rural. And rural is not only older, sicker, and poorer, which is commonly the headline that we will see. There are specific assets that are unique in rural communities, and we can draw from those assets when we are trying to disseminate work and when we are trying to engage community in our research projects. It is important to think about broadband access. So coming back to this lovely list you all created in the chat, we're seeing things like social media and podcasts and journals. These are all things we access online, even someone sharing Google or AI. Those require really strong broadband access, and we won't always have that in rural. There are also unique health-seeking behaviors, and you should understand and recognize those if you're disseminating results of research. And the implications call for action related to screening or utilizing services that just aren't available in rural. You don't want to have a conclusion in your research with recommendations that ask people to do something that is not available to them. So you need to be aware of what those variable services are in rural areas that are and are not accessible. So when we're translating knowledge to rural areas, whether we're trying to do health education or share research, we really need to consider if we're trying to translate to rural broadly, so a national outreach of rural communities, or if we're focused on one particular region. Rural Appalachia is very different than the rural South, which is very different than the upper rural Midwest. Who are you trying to focus your work for, and who are you trying to share it with? Let's start with if your goal is to reach rural broadly. If you want to reach rural audiences and through a rural network, what you want to do is before you do the grant or the research proposal, before you design your complex methods and submit it to some institutional review board for approval, figure out who you're doing this work for. And I used air quotes when I said for, because in rural areas, we should be doing work with rural communities and not for rural communities. We shouldn't be doing work that isn't of value to them. And so if you're in a rural space, you want to make sure that the research you want to engage in is something that rural networks care about broadly. Engage rural, whatever rural happens to mean for you, engage them before you design your research study. You can have ideas, you can have passion, you can have knowledge, you can be from a rural area, but you should still engage trusted sources in rural health or rural aging and disability services to figure out what is it that's important to this community before you start your research agenda. This is important because if they don't have, they being your community and partner that you're doing this work with, if you don't have their support early on and establish this reciprocity, they're less likely to read and consume the work at the end of the day. Is this a topic that matters? Is it something that's already been studied? And does it matter for the rural audience? So on my screen right now, there are 4 maps of the United States. All of them are representing designations of rural using different federal definitions of rural and urban areas. So for those who maybe can't see the screen or can't see the color differential, I just want to share that in the top left corner is a map of the United States, and gray counties are those that are considered rural. The red counties are those that are considered urban. The red shading in this image tends to all be concentrated toward the northeast and the southwest. The map next to it, dark green, is considered the rural area. On this map, those rural counties are almost all located centrally. The bottom 2 maps of the United States are both indicating counties that are distinguished as frontier and remote areas, or rural. In both of these examples, the one on the far left has far more counties that are shaded, but they're almost all to the west. When we get to the next designation, there are fewer counties that are shaded, and again, all to the west. There are none in the east except for the far northeast. I share this because it's important to note that these are all federally recognized definitions of rural. But which of these 4 you use completely changes your research and completely changes who you're trying to reach when you disseminate your work. And again, I've been working in rural spaces for nearly 15 years, and I think one of my favorite conversations I was ever a part of was being on a panel where we were discussing which designation should we be utilizing as we dictate the Centers for Medicare and Medicaid Services, and when we're doing funding allocation at a federal level. And my favorite example was somebody who said, I think we should just say that a rural community is one in which you can walk out and get into your car and find an eggplant in your back seat. Meaning, it is a rural area if you can A, leave your door unlocked and feel safe, and B, you will find fresh produce from a friend or a neighbor in the backseat of your car when you leave a place where you've left your car unlocked. That's rural. So when you're trying to figure out which definition of rural should you use, a recommendation if you're newer to this field and you're trying to figure out who your partners are, reach out to some of the really well-established partners working in rural health or working in rural broadly. On the slide in front of you are a bunch of partners who I would encourage you to reach out to if you are new to doing work in rural spaces and want to really have effective knowledge translation. These partners are not only working in rural health spaces, but I've also pulled for you chapters in constituency groups in national aging and rehabilitation programming, also the National Indian Council on Aging, the National Resource Center on Native American Aging. All of these groups are really great resources. Again, not a comprehensive list, but a good starting point. And as much as we all love and rely on email communication, I will tell you that the best way to reach these partners is to pick up the phone, make a phone call, and bring your skills and expertise, but not your ideas. And what I mean by that is when you want to have effective knowledge translation, we again don't want to come into this space and say, here's the research that I want to do on rural communities. Instead, it's better to reach out to these organizations and say, I have seen XYZ as an issue or as a solution. I have a passion for rural spaces, and here are my skill sets that I'd like to offer up. Is there opportunity for collaboration? That is different than opening up to an organization and saying, I'd like to come in and do research on your community. There is a difference between a communication plan and a dissemination plan, even though they do overlap. Communication is reciprocal. It's a conversation. It's a space where you're learning from the partners as much as they're learning from you. So when I develop a communication plan at the beginning of a research project, I try to figure out who are the right community partners that I need to have at the table, who can help me understand what this topic is I'm studying, how I should share it, and how often I should share it. And then I even create a communication plan with these partners. How frequently will I reach out to them? When will I update them on my research progress? And when will I seek them for their expertise and advice? I'm going to share an example of a study I was doing on the use of the emergency department for mental health diagnoses. This, again, I'm sticking to the national landscape. This was a national study trying to look at which diagnoses are most prevalent in our emergency departments, comparing rural and urban areas. I knew that was the topic area I had interest in. I knew that I was interested in rural spaces, and so I reached out to colleagues at the Federal Office of Rural Health Policy, Mental Health America, the Rural Health Research Advisory Board, the Substance Abuse and Mental Health Services agencies, and I reached out to these partners and basically said, here's my skill set, here's the area I'm interested in, what do you think is appropriate? And from this early communication, it was really obvious what their interests were. They gave insight on which variables might be of the most interest, and they even shared which data sets were and were not the best for utilizing for this research agenda. I was still the most expert in this group on research methodologies in rural spaces, and so I brought ideas as well. And keeping that communication open early, I was also able to say to them, before we do this work, who cares? Who will need to know about this work at the end of the day? And what will they need to know in order to make change? So I want to do this research knowing that it will have an impact, that there will be knowledge translation. And we had that conversation in month 1, early in our communication plan. And then as we started going through and figuring out which data will we look at, which results will we share, we kept communication open in real time in case we needed to change our dissemination plan, in case the results were giving us a different trend that wasn't relevant for the communities we had originally identified. So for an example, our dissemination plan, it had to change over time. We started the project and said, well, let's figure this out so we can educate emergency departments on what they might see, but so that we can also educate community on where the appropriate prevention points might be so they don't end up in the emergency department for some of these mental health diagnoses. However, when we began analyzing the data, that wasn't the trend we were actually taken aback by. It wasn't the thing that rose to the peripheral. It wasn't that emergency departments in rural are utilized more often than emergency departments in urban for mental health diagnoses, which was our hypothesis. Instead, it was that rural women were more predominantly utilizing the emergency department than any other group. And it was a particular age group. Well, this now changes how we share the results and who we want to share these results with, because it's no longer an issue of rural broadly, but we have a subset of individuals who are experiencing a greater inequity. So that changed our audience. We had a different group of individuals that we wanted to share this with. And one of the things we knew is we wanted to share these results quickly. When looking at national data sets, the data are often already 1 or 2 years old, if you're lucky, more often 4 years old. So we want to be able to, if this takes us 6 months to do this work, we want to be able to then share these results quickly. We don't want to wait a year for them to reach another journal publication. So our dissemination strategies to share this work was to think about the audiences that needed to hear about the results, and then figure out what the best strategy was for informing that audience. For fast dissemination, we created a policy brief. We shared this with legislative health aides, but we also created a policy brief that was more specific to hospital level policies that might actually improve the rate of individuals using the emergency department for mental health diagnoses. We did still write a journal publication, but the publication focused on educating our peers and our colleagues on how to use the same method to continue to track this trend over time and to inform them about what is happening in rural spaces. This was then published in the Journal of Rural Health because our focus here was on the disparity between rural and urban areas. We also quickly started preparing presentations because we wanted to inform rural public health on prevention strategies focused on women's mental health in rural areas. We wanted to inform clinicians on what they can see and screen for. So we went upstream to think about prevention strategies and not focused only on disseminating in the emergency department. We also created unique fact sheets that pulled out data points that were important to each audience. And to do that, we contacted them first. So we contacted the American College of Emergency Physicians and said, here's what we found. What would be great to share with your constituents? And we'll make a fact sheet that highlights those data points. We did the same with the Emergency Nurses Association, the same with the Society for Academic Emergency Medicine. The whole point was to say, we know the findings that are significant, but which of them matter to you that will actually influence change? What do your constituents need to hear? And what solutions can we recommend based off of this? And then we collaborated to share the results. I want to step back to the policy brief note for a minute because I saw a couple of individuals share social media as their source of information. When we share policy briefs, the goal is to give them to those who are making policy decisions and changes. Oftentimes, these are members of Congress, but we don't go to them directly. We typically go to their health aide, who consumes all of the information that they can around health topics to then inform the decision maker. A survey was done among health aides and all legislative aides at a national level to figure out where they consumed or where they first found information so that we could make better decisions. Their first source and the first place they turned to was Twitter, now X. As an academician and researcher, of course, that was disappointing to think we have all of these amazing articles out there to give you data-driven decision-making, and you're getting your information from Twitter or X. So maybe some of you have seen that many journals now ask you to provide language for the tweet or for the post, and then they are using social media as a way to lift up access to their policy briefs or journal articles or fact sheets. So there is a space and a need to draw upon social media as well to get your message out. So again, that was work that I am doing on a national landscape. We want to reach rural communities broadly. We want to reach those who are working in rural disability and aging services on a national landscape. But what if you're doing work in a rural community or at a more micro level? What are recommendations for that type of work? What is important is to know a couple of things about the community you're working in and with. And let me be clear that when I'm talking about a rural community, this might mean that you're doing research or knowledge translation in a single county, or maybe you're doing it in a rural state. Again, I'm located in North Dakota, a predominantly rural state. So oftentimes individuals will talk about health outcomes or disability services and rehabilitation for North Dakota as if we are all rural, which we are not. Or maybe you're actually focusing your work in the rural Midwest. Maybe you're doing work for individuals who are in the rural Appalachian area. So define what it is, what your community is, and then ask them, what do you consider rural? Another important consideration if you're working at a much more community level, or at least within a more narrow scope of rural, is to understand which areas are rural adjacent and which are urban adjacent. And that matters because if I'm in a rural community that is a size of 250, that is different than if I'm in a community a size of 2,500. And both of those are different if the next county is urban. So am I right up against Minneapolis, or am I in the northeast of Minnesota? Those are very different areas in terms of being a rural community. Get to understand the demographics of the rural area you're working in or with, because they are not, again, monolithic. Understand the racial, ethnic, and economic variability in that county. What is their number one industry? It is not always agriculture. It could be anything from communities that are striving in education because they happen to have a technical training site. It could be oil, it could be agriculture, but know what the industry happens to be, because that will impact the trusted sources within that community. It will also impact where you go to find people to participate in your work or consume your research. And understanding their trusted sources. Where do they turn to for information? And I'll give a few examples about those in a minute as well. So who are your local rural partners? Let's go back to the very beginning of this presentation when I said, whether it's at a national level or at a much smaller level, you should engage your partners early so that you know who you should be working with and so that you have allies in this work who will share your work when you're done. Some really great local rural partners include the local clinics, different coalitions. So think about the topic you're the most interested and engaged in, And there's probably a coalition working in that space. For example, a couple of rural communities have colorectal cancer screening coalitions, not even specific to cancer broadly, but literally focused in colorectal cancer. So think about who the coalitions are. And if you don't know, pick up the phone and call the public health unit. Call one of the clinics and ask, what are some of the local coalitions? What are they engaged in? What are the important topics in your community? Kiwanis and VFW, the county extension offices, these are all really great partners in work that you might be doing and who will give you a good pulse of what's happening in the community. There's also the local school board and faith-based organizations. And one of the things I would mention is that oftentimes, if you did a network analysis in a really small rural community, one person will represent 4 or 5 of these local partners. So feel free to do a bit of a snowball sample, essentially, of who are the voices to have at the table when creating your communication and dissemination plans. So let me share another example of this, of a research project that we engaged in that was at a much more micro level. So the last one I shared was looking at national data sets, really trying to understand what is the landscape of rural emergency department use broadly. Now, this project, I was actually contacted by a rural hospital CEO. And this is something that as you create those networks and partnerships and continue to show up and say, use me as a tool, the community will start to come to you and ask you and say, I know you have a strength in this skill. Will you offer it to our community and help? So I had a rural hospital CEO reach out to me and say, anecdotally, at the peak of the pandemic, my staff are depressed. They are stressed. They are anxious. I know we're reading it in the news. I know we're hearing about it, but I can't, as a hospital CEO, I can't develop interventions or write grants or bring in money based off of story. I need evidence. What kind of research can we do to show that our hospital staff need mental health supports? So then in typical fashion, I said, well, let's reach out to our partners in North Dakota, because this was a North Dakota hospital CEO asking a North Dakota question in order to influence North Dakota legislators to put dollars into mental health supports. So I said, let's talk to our state office of rural health. Let's ask them what they're interested in, and let's make sure they're not already doing this work. And then we said, all right, now let's talk to our North Dakota Rural Hospital Association and our North Dakota Rural Health Association and our Critical Access Hospital Quality Network, which is made up of nursing staff. Let's talk to those partners, hear what they're doing, hear what they're seeing, and ask what would be most helpful and valuable to them. What do they want to know? What do we need to measure? And what do we need to report to make change? So then we even asked some of our legislators in North Dakota who dissemination planning, right? That's who we want to read this at the end of the day. So we asked them, in order to have effective knowledge translation, what do you need to know to inform your decisions? And from that, not only did we build trust, not only did we develop strong partnerships, but then we already had an entire network of individuals waiting to hear the results of this research. They were eager. And so they even started checking in with us. How's it going? Do you have approval yet? Do you have results yet? What have you learned? So the questions we were interested in is not only what is the mental health status, but is there variation between urban and rural? Because one legislator said, I'm glad you care about rural, but I care about our state broadly, and I think it's everybody. Ask it of everybody. And North Dakota happens to have a very unique infrastructure. We are very different in terms of the East and the West, in terms of culture and attitude and beliefs. So they said, also look at East and West. So we had to create a question between East and West. And then we had mental health advocates who said, can we also identify protective factors, things that are helping them in this space so we can find what our best practice is, what people are doing to stay healthy? And so we added that to the survey as well. So we finished this work. And at the end of the day, the purpose was to change policy at a hospital level and at a state level so that people could better support those who were working in our hospitals. provide the mental health supports that they needed. We needed to be able to change hospital policies, and we needed to be able to change state policy. But again, turning to this beautiful list of ways that you all consume research, we couldn't wait a year to have this published in a journal article. So our first point was to create a policy brief that we could share with hospital administrators. Here are policies you can do at a hospital level to improve mental health and wellness of your staff. Clinicians, everything from frontline staff to those who are administration. And then a policy brief for legislators that said, here are the data points that you care about, and here are the things you can do to make positive change. And then we gave presentations at a national stage to say, you should do assessments like this in your state as well. Figure out what your communities need and then develop interventions. But now my favorite example to share with you all in terms of how to have knowledge translation in rural spaces is that from this, when we had asked community ahead of time, our hospital staff had basically said, please don't come in here during a pandemic, during a time of high stress, and make me take a survey to then at the end of the day have no reciprocity. I don't want to just hear what the results are because I already know we're in a bad space. Do something about it. So we knew as researchers that we could not ethically start this work if we didn't have a plan to do something about it in the end, and not just write the policy brief, but translate this knowledge in a practical, tangible way that moved from bookshelf to bedside. It actually changed what tomorrow looked like for those who took the survey. So from this, we created a rural toolkit. The toolkit was called Building Resilience Among Physical and Behavioral Healthcare Providers During a Global Health Pandemic. But what it did is it used the data, it used the research results to create actual opportunities for self-care that were tangible and practical. It walked readers through case scenarios of a rural primary care provider, helped you identify signs of mental and emotional and psychological distress, had resources of where you could turn for free mental health counseling for physicians, spaces that you could access care, but it also offered individual things that they could do for balance. In fact, one of my favorite recommendations that came from this toolkit that our hospitals adopted was having grocery services for hospital administration and clinical staff so that when they left the hospital at the end of the day and their shift finally ended, their groceries were waiting for them to take home. Not an app they still had to fill out, a place they had to go pick up and then take home. It was there at the hospital. So this was a partnership between grocery and the hospital, because that was one of the more tangible things they identified and said, I don't even have time to take care of my family because I'm so busy taking care of patients. And that's an example of knowledge translation where we did the research study and we took that one project and we disseminated it in a multitude of ways so that we reached diverse audiences. This is not a comprehensive list, but I wanted to provide a resource for you all if you're thinking, where can I start to find rural partners? So this is just a resource slide listing different tribal organizations, agriculture and farming organizations, workforce development groups, community-based organizations, to give you a starting point if you're new to engaging and providing knowledge dissemination and translation in rural communities. So again, in terms of rural reciprocity, consider the opportunity to engage rural, whatever rural is for you, engage that community early. Create a communication plan, and this can be anything from a detailed and written communication plan that is very formal to an informal digital sticky note where you have a running list of partners you're going to reach out to and when you plan to reach them. Keep that conversation emergent and keep it going throughout. And once you've listed those partners, do not be shy about picking up the phone and calling. Rural communities tend to be relational, and that will really benefit your projects. A great example I like to share is that for one of our studies, we were trying to engage all of the business organizations in rural communities so that they could help us roll out a survey. And so we were calling different business groups, and one of the groups that we had to call, they basically said, oh, well, you can reach Steve, but you have to call Steve at the John Deere store because he volunteers over at John Deere in the evenings on Thursdays. So then we called the John Deere store, and then we asked for Steve, and Steve doesn't keep a cell phone, but you can call back. Steve likes to go out for dinner about this time, so call back at 7:30 in the evening. And so we did. We called the John Deere store at 7:30 because Steve doesn't like taking calls at home. And that's how you create relationship in rural communities and make sure you have reciprocal trust, and that I knew I was engaging the right partner, and I could ask Steve, not his real name, I could ask Steve, what's important in your county? If we do this survey, what's going to be useful for you? And how do we make sure we're not an extra burden? So don't limit yourself to just one. A lot of you, again, in the chat, you shared that you get things from the news, but also social media, also journals, also Google, also email alerts. So don't limit yourself. If you have finished doing a research project, yes, we have to be careful of plagiarism. So if you plan to do a journal article, most journals will say you cannot redistribute this content or knowledge in another format. So be selective in what you share and where, because you want to make sure you don't limit yourself. If the purpose of this work is knowledge translation and you want to see change, you want to have data-driven information, data-driven decision-making, think about how to share this. Think about who's going to engage and amplify your message. You can get influencers, and I'm not talking about just TikTok influencers. I'm talking about in a rural community asking, who is it that has a lot of influence in your rural community? It might be someone you hadn't even thought of. It might be somebody who is a really great, does really great on the rodeo circuit. And she happens to just be stellar and people love her and trust her. Use her to share the knowledge and information. Let her go on the radio. Think about different messaging that you need to use for rural communities. Think about effective channels to communicate. You can see on here a couple of different options, but these are the typical spaces, right? We can share chart books, infographics, testimonies, images, flyers, but you can also share at health fairs. You can go to community events. In rural communities, you can go to the county fair, the state fair, share at a booth. This is a great place to do knowledge translation, especially if you're trying to reach community and not just decision makers. So rural considerations, there's a 211 system that you can use for sharing information. When we were doing agricultural dissemination and we were working on mental health supports for farms and agricultural producers, one of the things that we talked about was how do we reach them? And we brought together our rural egg producers, leaders in rural agriculture, and they said, I typically listen to AM radio and I listen to YouTube and I listen to talk radio. So we asked them what the most common stations they were listening to were, and then we created dissemination in those formats because that's who we wanted to reach. We were trying to reach our rural producers. And the only way to do that is to go through the channels they are using, which happened to have been at that time, local radio and a really popular YouTube video that they would watch while in their tractors. So we asked them, well, who is that? And we reached out to them and said, can we share on your channel? So thinking about those news sources and always going back to community and asking them, where do you get your information? So to leave time for questions, I just want to leave you with this knowledge that if you want to effectively share information with rural communities, use your trusted rural networks, go to the schools or the churches or the community organizations, make sure it is credible engagement and that you are doing reciprocity. You are not engaging them for the benefit of your work, but for the benefit of collaboration. You can still do traditional media, journal articles, and releases that you are comfortable with, but also consider different tools that are valuable in rural communities. Tailor your messages. Make sure the images you use do not reinforce stereotypes of rural, but instead celebrate rural spaces. Use storytelling, mailed materials, Think about varying levels of literacy when you consider your audience that you are turning to. And remember that if you wanted quick response in research participation, they should also be welcomed a quick response in sharing the results. Effective communication results in strong dissemination, and then community will actually do something with the work that you've produced. I am always happy to talk about the rural assets and what we've done. I have probably another dozen examples, from colorectal cancer screening research that we've done to other health equity projects to creating cultural tools and healing for ceremony-assisted treatment in our Indigenous communities with my Indigenous health colleagues. And I'm always open to talking about them. So this is my contact information. You can reach me at that email, at that phone number, or through LinkedIn, and I would be happy to share more. So with that, I would like to open to see if there are any questions.
Thank you so much, Dr. Schrader. That was a lot of helpful and incredible information. Thank you for sharing with us today. I did have a quick question. You've been doing this for nearly 15 years. It's, clearly an expert. If some organization or if some researchers are just starting out, what are some pitfalls or barriers that you encountered maybe earlier in this journey that is a cautionary tale for those who are just starting?
Absolutely. So my solution first is find your state office of rural health and find the National Rural Health Association. Join those two groups, reach out to those two groups immediately, because some of the pitfalls that you will make is I grew up rural, and so I knew my rural area. I knew North Dakota and I knew Minnesota, and I had made my own assumptions. So even being rural, we create our own assumptions or stereotypes of who our communities are and how we serve them. And to recognize that it isn't monolithic. So don't make assumptions about one rural community based off of the experiences that you've had with another. And that can be a tough lesson to learn. I think also important is that if you're doing research in one particular area, don't assume it's going to relate to another. So for example, I did a lot of work in oral health equity in rural spaces, but the barriers that they were experiencing related to oral health were not related at all to their perceptions and their decision-making around cancer screening. And so just being open to knowing that if you know one thing about one thing, you know one thing about one thing in rural, and just to be open to understanding that each endeavor is completely brand new.
Another takeaway that I took from your presentation is just picking up the phone and calling people. And in this world of emails and newsletters and sort of a, one step back approach to engagement, what recommendations or advice do you have, especially for researchers or their dissemination folks, when calling is not an option, or should they focus focus their energy and efforts on that?
Yes. So my first answer is calling is always an option if you actually want to have impact. And so if you don't have a lot of time, because I know at the very beginning I said, know your resources, know what you have for time. Make the phone call to the highest level. So make the phone call to the National Rural Health Association and make that relationship, because they already have partners in every state. So then you don't have to call every rural association. Or if you're trying to get to more local, so if I were in Minnesota, I might call the Minnesota Rural Health Association. That will be my one phone call, and they can reach each county, because I don't have time to call every county maybe. So that phone call is really an excellent touch point in a world in which we are drowning in digital communication and email and invitation.
Great, thank you. And we have a question in the chat. So when working with stigmatized populations or conditions, for example, HIV outbreaks similar to the one in Scott County, Indiana, what would we need to keep in mind when it comes to dissemination and recommendations, especially when there has been community backlash against some of the solutions, in this case, harm reduction?
This is an excellent question, and we've faced this in a lot of spaces. So we've had this when we were working with COVID vaccination, or even mask wearing at that time, or harm reduction strategies in the opioid crisis, syringe exchange programs that we've tried to put in rural spaces. And the best success is to find a trusted source in community who can be the voice, because we won't otherwise overcome those barriers and changes. And so oftentimes it took getting the really older as in had been in the community for the longest time, the trusted doc, to come on and say, can you all just wear your mask when you come into the clinic for me? I know you don't like it. It's probably not doing anything for you, but do it for me, because I am at risk. So it was about finding the trusted sources and flipping the message a little bit. It maybe isn't the message I wanted them to send as a public health practitioner. I knew that wasn't necessarily the best practice of saying, just wear it for me, but never anywhere else. But it was that or nothing. And so trying to find that trusted source of and then working with them and asking them, how do we do this? Who do we talk to? One other recommendation that we've done in rural, which it's not comfortable and it was really tough to do, is to bring in and do focus groups with those who don't want the message. So we did that around colorectal cancer screening. We brought in, it was in a rural agricultural community among gentlemen who found it really stigmatizing to even talk about colonoscopies. And we brought them in and just said, let's talk about this. And you have to tell us how we reach community. And we had really uncomfortable conversations where they got to sort of belittle academia and education, and we allowed them to. And then we said, but what message will work? Because here's what we know. And so that it's time intensive, it's resource intensive, but in community, asking for them, letting them choose their messenger, and letting them speak the message, even if it's not everything you want it to be.
Thank you. Thank you so much for your time and expertise during this webcast. Thank you to you, attendees. If you have a moment, please fill out our evaluation. This gives us great insight on the type of activities and events we hold in the future. Thank you, Shoshana. Thank you to our ASL and CART interpreters, and we will see you next time. Have a good day.